Hello everyone, my name is Marielle Milana and I will be your host for today's Global Grand Rounds. Today's presentation is CME approved, so please click the link in the chat box to receive your CME credits. Today we have our Global Offsite Medical Director, Dr. Pekia, who will now be introducing our presenters for today.
Great, thank you, Marielle, and again, welcome everyone. Just a reminder, this session is being recorded so it can be accessed for later viewing, and I think up to a week afterwards also for CME credit, after the session today. So as Marielle mentioned, I'm the medical director for Global Offsite Care and also a geriatrician and assistant professor of telemedicine at Western University of Health Sciences. And so glad to and happy to have our guest speakers here today who I'll introduce in order. Melanie Barbee is an RDN, CDCES, who is a clinical and community dietitian. She's a patient educator and assistant adjunct professor, mentor, and researcher who provides students medical nutrition, therapy, and lifestyle medicine content. Jose Zamora is a PharmD, Doctor of Pharmacy, and one of the current community pharmacy residents with Western University of Health Sciences. He graduated from Western University of Health Sciences with a Doctor of Pharmacy degree. And additionally, Dr. Airani Sathananthan, MD, is an endocrinologist and professor in Department of Internal Medicine at Western U College of Osteopathic Medicine of the Pacific, and has so kindly spoken at this session in the past on other topics. She is involved with teaching, research, and patient care at the university, and is a particularly adept and experienced clinician in the virtual space, utilizing telemedicine to deliver diabetic care and general endocrinology now for some years, and we do greatly appreciate that, Dr. Sathananthan. And with that, I will hand it off to you to start the session. And thank you all again for attending today and to our speakers today.
Great. Well, thank you for having us, Melanie. Jose and I are happy to be here to basically share some of our recent experiences using telemedicine and CGM and medical nutrition therapy through our diabetes clinic. So we have just some overview information, and then we have a few cases we wanted to go through, and then we're happy to take any questions and open up to a discussion. So you can see our objectives there, and then our disclosures. And I pulled a few slides from the American Diabetes Association Standards of Care from their diabetes technology section. And basically there are two main ways for glucose monitoring. One is a glucometer, which most of us are familiar with, which measures the capillary blood glucose. And now we have continuous glucose monitoring, which monitors the interstitial glucose. And with the increased use of CGM, this has really changed how we can treat patients, as well as the type of data we can get, and has also made it easier for us to see patients on virtual visits and with telemedicine, because we have a lot of additional data that we didn't used to previously have. So when choosing a device, obviously you have to look into the patient's specific needs, what's available, their skill level. If you have a young child with diabetes, obviously the parents may also have access to their glucose readings, and with some of the newer technology, this has been much easier to do. In addition, it's important for the patient to receive training either in person or remotely. And often our pharmacy team here, which Jose is a part of, does some of the in-person training for patients on these types of devices, because it's important for us to know, for them to know how to use them correctly, as well as how to upload and share the data with us. So all patients should be provided with a blood glucose monitoring device, and those who are using a continuous glucose monitor device should also have access to a blood glucose monitor, because if there's any discrepancy, we ask them to use a traditional glucometer to verify the reading. Most people on insulin, depending on what type of regimen they're on, may be asked to check up to 4 times a day, but with on a traditional glucometer, but with continuous glucose monitoring, they will have readings throughout the day. In addition, it's important to check your glucose if you have symptoms if you feel you're having hypoglycemic symptoms, as well as when treating hypoglycemia or performing any critical tasks such as driving. It would be good to check your glucose prior. It's important to know that there is a difference in accuracy among different glucometers, and it's important to use strips that are not expired. And although we recommend that most patients with diabetes have access to a glucometer, it doesn't necessarily mean for patients, I guess, who are not on insulin, it hasn't consistently showed a significant reduction in A1C, but often, even if a patient is not on an insulin therapy, they can benefit from checking their glucose in order to make changes in their lifestyle. And of course, there are certain oral agents that can also cause hypoglycemia, like sulfonylureas. So using those sorts of, with those sorts of agents, it's important to have a way to check your glucose. So getting into continuous glucose monitoring devices, there are real-time or intermittent scan glucose monitoring. There's also a professional glucose monitoring that can be used by physicians, where they place a continuous glucose monitor on a patient in the office. It could be blinded to the patient, or it could be unblinded, and then the patient returns in 10 days to 14 days to have that removed, to have the CGM downloaded, and for the physician to make changes to the regimen. With continuous glucose monitoring devices, you have to be aware of skin reactions, because most of the time these are being ordered for 10 to 14 days. And so the issue of them falling off early, getting irritation from the adhesive, should all be evaluated. And there are also certain interfering substances that might interfere with the accuracy of the continuous glucose monitoring. And so I'll show you that in a second, some of the substances to be aware of. As I mentioned earlier, there's real-time glucose monitoring, and then there's also intermittent scanning, where the patient wears this CGM device and then scans with their phone or a reader to get periodic readings. And then, as I mentioned, the professional CGM is also an option. So here are some of the devices, not devices, some of the substances that could interfere with the continuous glucose monitoring device. Probably the most important one to be aware of is acetaminophen or Tylenol, and alcohol also. And for acetaminophen, you could have a higher sensor reading than the actual glucose. With the continuous glucose monitoring devices, there are several metrics that are provided. And this is in comparison to a traditional glucometer, where we would just get periodic readings throughout the day. So with a glucometer, we would ask the patient, for example, we would see what their reading is in the morning, then maybe before lunch, before dinner, and at bedtime. And if there was any hypoglycemia, we could try to identify, if they checked, at what time that was occurring. With the continuous glucose monitor, you get more of a comprehensive report, and this figure lists some of the information that you can gather from their report. So It typically includes the days worn, the percentage of the time the CGM was active, the average glucose, the glucose management indicator, which is similar to a predicted A1C, the glycemic variability. And then you can see here, the new thing now is time in range. So what percentage of the time the patient is in range for the period they're wearing the CGM, and then what percentage of time they're above range, very high above range, or below range, or very low. So these are some of the new metrics that we can use when evaluating patients for diabetes. So time in range has become more popular. We talk about the A1C, but now time in range is also very important. And you can see here what the goals are for time in range, time below range, and time above range. And in this figure, they've split it between type 1 and type 2 patients versus patients who might be older or at a higher risk. So you can see here, for a typical type 1 or type 2 patient, you're looking at a time in range greater than 70%, which is defined as between 70 and 180. You're looking at a time below range less than 70 of less than 4%, and a time below range of less than 54 of less than 1%. And then a time above range more than 180, 25%, and more than 250, 5%, less than 5%. This is in contrast to older adults, where you really do want to avoid hypoglycemia. So you can see less than 1% for glucose is less than 7, a little bit more, the target range 70 to 180, greater than 50 versus greater than 70. So a little bit more flexibility there. And this just visually describes a patient who's at higher risk. It's important to avoid hypoglycemia, and you might accept a little bit more hyperglycemia versus a typical patient with type 1 or type 2 diabetes. You'd like to see their time in range approximately 70%. This diagram describes two different studies that were done, which shows, as you increase the time in range, what is the predicted A1C reduction. And the first study by Beck was done in patients with type 1 diabetes. And in the second study, they looked at patients with type 1 and type 2 diabetes. And so you can see here at the bottom, for every 10% increase in time in range, there was an approximate 0.5% A1C reduction. And in this study, for every 10% increase in time in range, there was an approximate 0.8% in A1C reduction. So you're looking at between 0.5 and 0.8% reduction in A1C for every 10% increase in time in range. So now I'm going to turn things over to Dr. Zamora, who, as Dr. Pecchia said, is one of our resident pharmacists here in the clinic, and I'll let him start explaining about the different types of CGM devices.
Hi, everyone. So for the different types of glucose monitoring systems, or CGM devices, those are the four most common ones on the market. So we have the Dexcom, the Freestyle Libre, the Medtronic, and the Eversense. Just to quickly mention some little differences between each one. The Medtronic only works with their own devices, such as their insulin pen pen and pumps. And then the Eversense is very unique as compared to the other ones, because it's the only one that's actually an implant, such as like a hormonal implant on the arm. And it could be worn up to 3 months, and it still needs a reader. And one factor with it in the US is that it can only be applied by an endocrinologist. Now, to further compare all different types, four of them, as Dr. Sathananthan mentioned earlier, there's intermittent and real time, pretty much for all the CGMs. They're all measure the patient's glucose levels in real time. The Libre is a unique one, as it also measures an intermittent time, meaning you need to kind of scan it every now and then, and that's very specific to the Libre 2 that they have. Component-wise, they all contain sensor and transmitter and a reader, So again, with the Eversense, it's an implant, and the Medtronic, it only works with their own devices. Compatibility wise, they're all compatible with most smartphone apps and watches. However, with Medtronic, as I mentioned earlier, they're very compatible only with their devices, like the InPen that I mentioned, or pumps. But for app wise, they're only compatible with the Apple smartphones. And then the Dexcom is actually the only one right now that's compatible with other insulin pumps, such as a Tandem and Omnipod. Software-wise, they all have the unique CGM software to look at their insulin levels, their glucose levels. And then the MARD. MARD, that stands for mean absolute risk difference. It pretty much measures how accurate their levels of measuring their interstitial glucose to actual blood glucose. So the lower the number, the better. So you can see the lowest number here is actually from the Libre 3. It's at 7.9%. And the second lowest number would be from the Dexcom G7, which is at 8.2. Age of indication, Libre starts at 4 years or older. Dexcom could go as young as 2 years. The Medtronic, you could start at from 14, but you have to stop at 75. And the Eversense, being an implant, the patient would have to be 18 years or older. And duration of wear, again, Eversense being the implant has the longest duration of wear, being 90 days. And then Medtronic has the shortest, being 7 days only. Dexcom 10 days, and the Libre having 14 days. Next slide, please. Thank you. Now, to show you guys real quick how it looks like on their software to look at the report, you can see here on the top left of the report screen, you can see the bar for looking at the target in range. And you can see that the patient here, for example, is at 46% in range. And the goal, so they're under goal of that 70% or higher that we want to have them. And then they're high, meaning they're 24% in high, 20% in high, and being a total of 44%. So you can see that there, that they're, again, above that goal. We want to have them less than 25% of that. Now, to the right of that, you can see the glucose management indicator, or the GMI, which is, again, another way to look at their A1C, similar to looking at something like A1C. It's at 7.5%. And then to the bottom, you can see the whole graph right there. See how the levels are throughout the day. So you can see on the x-axis to the bottom is the time of day. So you can see at 12 p.m., they're in target range. But however, once you get to around 9 p.m., they're above that target range. Now, to give you guys a quick example of a case here. So here we have ML, who's a 40-year-old with type 2 diabetes, chronic kidney disease, stage 3, hypertension, and hyperlipidemia. Just to quickly note some of his meds. For his diabetes, he is on a SGLT2, a GLP-1, and he is on a basal bolus insulin therapy, along with the CGM here noted, you can see is a Dexcom G6. And lab-wise, just to quickly note, his A1C in May of this year is at 7.3. And for the case here, you can see this is just a report we pulled to see from February all the way to May of this year. So you can see his average glucose is at 193, and with his GMI, or the glucose management indicator, is at 7.9. You can see that to the right of that, in the time in range, he's 50% in range, and for the other half, being the 33 and 60%, which is 49%, is high. So you can see to the bottom of that on the graph, you can see all his levels being very high throughout the day. Now, this is just to show you guys a quick comparison for the same patient here. So we pulled a report from 14 days of the beginning of August, and then another 2 weeks towards the middle and end of August. So on the left side, you see that the patient, here's where the patient had the basal bolus therapy, had injections about 4 times a day, and the right side is when we made adjustments to his therapy. So you can see after making adjustments in his therapy, his time in range went from 36% in the early August to the middle and end of August, going to 80%. And then his highs reduced from 44 all the way to 18, and his very highest reduced from 20 to 2%. So just to point out that after making these adjustments, you can see these changes and improvements in the patients rather than waiting for an A1C in 3 months. So you can see the changes that we made to the patient's therapy. So the patient was still on a SGLT2 and a GLP-1, but we started him on the automated insulin delivery system, or the insulin pump, Omnipod 5, along with the rapid insulin, and then still use the Dexcom G6 just to continuously monitor his glucose levels. So we took him up to basal. And you can see also on his labs, when he came back, his A1C improved in September, dropping from 7.3 to 6.6. And now I'll have Dr. Sathananthan can explain some more cases after this slide here. So the key takeaways would be that patient preference wise, you always want to have a preference. So as mentioned earlier, some patients might want to maybe have a glucose monitoring device on their stomach instead of their arm. And there's two of those devices actually. That would be the Dexcom G6 and the Medtronic would be the only ones that are FDA approved to be on the abdomen. And then also other, like maybe they don't want to change it so often. For example, maybe they want to have an implant, have it on for 90 days instead of changing it so often, like having a Dexcom, which is every 10 days. And then compatibility with devices. Some patients might prefer, like an older patient might prefer having a reader than actually using a smartphone or app. So those things to consider if the device has a reader that comes well with it. And overall for telemedicine and having that CGM software, it leads to that easy access to these readings to make any lifestyle changes and treatment decisions, not including medications only, but also changes in their habits. So you can start seeing the improvements in their levels right away without waiting for an A1C in 3 months.
Thank you, Jose. I had just two brief cases here. So the first one is Vian, a 74-year-old female with type 2 diabetes for many years. She does require translation, and so it's easier for her to do some of her visits from home where she has family members who can translate and also be there with her during the visit. And she also has some transportation problems, so many of her visits are done via telemedicine. So you can see here her medication regimen. She's on metformin. She's on an SGLT2 inhibitor. She's on a GLP-1 receptor agonist weekly, along with some basal insulin. And she's also using bolus insulin with all three of her meals, along with the correction scale. So you can see here that her A1C improved from 9.9 to 7.5. And in fact, we didn't make too many adjustments to her medication, but between these two time points, she did get on a CGM device. And that really helped this patient to see in real time how her glucose was being affected by the different foods she was eating. And so she was really able to make a lot of changes in her diet, as well as increase her her activity level to help improve her glucose. So you can see here the GMI is 7.2%. And you can see here that most of the time she's in goal range. And then at around her mealtime, so after breakfast, after lunch, and after dinner, you can see she has some small postprandial spikes. And so after seeing these readings and this output from her CGM, we were able to adjust up her bolus insulin a little bit to address these spikes. But for the most part, you can see she doesn't have any hypoglycemia. She's wearing the sensor very regularly. And so she had made good progress since getting the CGM. So in this patient, telemedicine was useful because of her transportation and language issues. Using the CGM technology, we were able to visually show her where medication changes could be made and encourage her to use a little bit more bolus insulin with some of those meals. And then for this particular patient, just use of the CGM helped her make a lot of lifestyle changes, which improved her overall A1C. The second patient is also another elderly female who's had diabetes for many years. She has a visit today because of sudden increase in glucose over the past several days. And in fact, the same patient has been also managed by both Melanie and Jose. And she cannot read, but she can read numbers. And so she was also placed on a CGM device. You can see here she's also using a basal insulin, glargine, a weekly GLP-1, and then an SGLT2 inhibitor, and her A1C was 8.5. So she felt she had been doing reasonably well. And you can see here September 16th, most of her glucose readings were within range. She has some small spikes here, which appear to be after breakfast, and then probably again here after dinner. But then suddenly she started noticing that her glucoses were very high, and she was concerned. After further talking with the patient, and reviewing her medication list, we found out that she was started on a glucocorticoid here for some inflammation that she was having. And so that attributed to these higher glucoses. And so she was able to visually see that happening. We were able to see that too, and we could make some temporary adjustment to her regimen until she was done with the course of glucocorticoids. So in this case, a quick telemedicine visit helped us to see what was happening with the patient's glucose, and helped us to address the issues quickly by just temporarily adjusting her medication. And this also helped reassure the patient that she could clearly see when the change happened and then relate that to her change in medication. I'm going to turn things over to Melanie Barbee now.
Thank you, Dr. Sathananthan and Dr. Zamora. So I'm going to start with a case study. And I just want to give you a little bit of background on this gentleman. He's a very tough guy. He was struck by lightning in 1997 and survived that, and is really up for any challenge. So I just want to give you that background. I really enjoy my sessions with him. And during COVID is when we really did a lot of telehealth work together. So he is a 64-year-old male with previous medical history of type 2 diabetes, hyperlipidemia, hypertension, chronic kidney disease, mild stage 2, OSA, so obstructive sleep apnea, bilateral neuropathy, and acquired hypothyroidism. The neuropathy has also affected his fingers, so it's very difficult for him to manage certain devices. And we are working with him, with his insurance, to just to tie in with Dr. Sathananthan and Dr. Zamora's presentations on utilizing CGM to help him with his blood glucose goals. So some of the dietary challenges that were seen with the patient was his whole milk intake. He was drinking approximately 3 gallons of milk per week. He was also taking in quite a lot of processed and cured meats, lots of red meats and pepperoni, salamis, things like that, deli meats, and a very high intake of frozen and prepared foods. Then his A1C at the time that I started with working with the patient was about 8.9. And prior to that was in the tens, but really started honing in on he was ready to start talking about lifestyle changes in February of this year. So our goal for him was to have his A1C less than 7 and to increase his more whole foods, that is foods that are, fresh fruits and vegetables, whole grains, and actually start making more food himself and cooking. He lives with his son, who is a nurse, and was very interested in coming up with better ways to prepare foods at home. His weight goal was set by him at to be under 235 pounds in 9 to 12 months. And the patient was 330 pounds in 2018 and has made great strides himself in weight loss. So how telehealth really helps me as a dietitian is providing medical nutrition therapy is, I call it the show me. When patients that are using telehealth say, I eat this, I just bought this supplement, I'm taking this and that. And I just say, show me, since I have the ability to look in their refrigerator, look in their pantry, and they basically are showing me everything that they're eating. And as they progress with follow-up appointments, I know that the gentleman that I was speaking of earlier, he said, look how many fruits and vegetables I have in my refrigerator. I'm drinking 1% milk and counting it as a carbohydrate, whereas before, some of the highs he was, postprandial highs he was experiencing were because of the high milk intake. And then that also was a teaching opportunity, for me to let him know that milk, just because it's lower in fat, does not mean it's lower in carbohydrate, because those two things tend to get a little bit confusing for patients. And with that, there's so many meaningful teaching opportunities as a dietitian when we're doing telehealth. Again, looking at food labels is so important. One of the things that I explain to my patients that I have the opportunity to provide telehealth is the front of a label, the front of a box, a jar, a frozen food, whatever that might be, is sort of the hook. You know, it brings you in. It might have information that seems important, gluten-free, which is for some folks, but many, if that's not a serious concern, or non-GMO or whatever the situation might be. And made with all these different things. And so it's like the advertising, it's the hook to bring you in. But the nutrition facts label is what we really have to pay attention to. And just for an example, a half a cup of a pasta sauce that our patient was using has 480 milligrams of sodium. ADA recommends 150 milligrams or less per serving. And half a cup is a very unrealistic amount. Most people do not only use half a cup of a pasta sauce when they're having spaghetti, for example. So there's a lot of teaching moments there. And then half a cup of sauce, because there is sugar added to this tomato sauce, has 13 grams of carbohydrate, or basically one carb exchange, you know, one portion. So there's a lot you can learn. If someone has more advanced kidney disease, we have to look at potassium and things like that. So it's very important to look at the food labels. And when a patient is at home, we can look at all their food labels. So another teaching moment, for example, there's so many different breads out there. Breads and cereals are probably the two most inflated aisles in the grocery store. You know, both sides, walk in the grocery store and there'll be a whole row and both sides will be cereals. And they all claim to be healthy in some way. So it can be very confusing for folks when they're looking for a healthy alternative for breakfast. So again, we focus on one slice of bread has 19 grams of carbohydrate. If a patient's on an insulin carb ratio, that's another meaningful teaching opportunity to be able to discuss that. This patient happens to be followed by Dr. Sathananthan, who referred the patient to me, Dr. Zamora, and Dr. Pham, our clinical pharmacists. So he also has his primary care, a podiatrist, and nephrologist all under our roof at the clinic. So we have a real opportunity to do some interdisciplinary work, both in clinic and telehealth. So with all of these providers, it's really meaningful for him to understand the food part of it. And I've heard, you know, feedback from the patient saying, oh, you know, Dr. Barnes, a nephrologist, was really impressed that I knew about this, that, and the other. And it's because of that food label I showed you at home. And then also like yogurts, there's so many different yogurts as well. And some of them have a high amount of protein and live food cultures, but there's a lot that have jellies added to the bottom. And again, they look real healthy on the front, but we need to really read these food labels. This gentleman also bought frozen fresh hamburger patties that were already done that, hey, they sound really convenient. But, when we looked at the food label, which is not pictured here because there was a brand, but that food label indicated that each hamburger patty had approximately 450 milligrams of sodium. And so that indicated that it was spiced, you know, not only with spices, but also salt right before they were frozen. So we made a switch over to some hamburger patties that were frozen and did not contain any spices. And you see the difference here with about 55 milligrams per hamburger patty. Again, the processed meats, there was a lot of teaching opportunities there, and the milk, just understanding how much carbohydrate, when we drink carbohydrate, that certainly increases our blood. We get a glucose excursion that's much higher spike than when we're chewing, swallowing, especially if the food has a nice amount of fiber. It takes longer for that spike to go up that Dr. Zamora showed us in his patient case. So label reading is, patients don't typically bring all their groceries when they see me, I wish, but certainly telehealth gives us a real, look into how folks, are preparing their foods, what foods they're buying, if they have supplements. Protein powders also have and have a facade of being super healthy and super, part of your diet and all those things, when sometimes they can have a lot of additives that could really be detrimental for kidney health, for example. So some of the highlights for me with telehealth is the barriers to follow-up care. Typically, I like to see patients if they need more intense follow-up monthly. But if they have, transportation barriers or distance, this patient particularly, specifically, he lives up in the mountains. And you probably heard, last winter in California, we had an amazingly over the top amount of rain and also snow in our local mountains. And this gentleman was snowed in for 2 weeks. He also is managing multiple healthcare appointments with myself and the other team members that I mentioned. So telehealth was a really important way for him to stay in touch. And because of his limited mobility, his advanced neuropathy, also safer for him to have telehealth appointments. The gentleman asked me to pass on some of his comments, that he felt that having telemedicine, especially during COVID and during these crazy weather times, that he felt closer to his providers. He said it felt like he was receiving a more personal touch by continuing to see his same providers that he had seen in person. He felt that it built up his trust in between appointments that were in person to have these telehealth opportunities. So some of the medical nutrition key takeaways that we've experienced as far as a dietitian's perspective is it's very convenient for a patient who experienced transportation, mobility, and childcare limitations. I have a lot of patients who either have children themselves, or they are patients who are grandparents, and they are charged with watching their grandchildren and have multiple schedules of drop-offs and pickups and those kinds of things. And telehealth works really well for those patients. I also have, second to my diabetes population, which is my highest level of patients that I see, are the bariatric patients or the weight loss surgery patients, who insurance companies require 3 to 6 visits. So when the patient requires 6 visits monthly, it makes much more sense to see that patient, connect with them in person for the first appointment. Then we schedule 4 telehealth appointments, and then the last appointment is in person to go over what's expected after their surgery. So for bariatric patients, also works fantastic. Also for continuity of care, reduced loss to follow-up on some patients that have these limitations that we mentioned earlier. And then with telemedicine, as far as a dietitian's perspective, you get a perspective and an in-depth chance to see what's in their kitchen, in their refrigerator, how they're preparing the foods, food labels, all shared in real time. I've had patients show me, look at this new scale I bought, look at my elliptical machine, and all of those things really increase the experience for the patients when I think they're in their own home, able to share these experiences and some of the successes they've had. Thank you very much.
Thanks so much, Melanie. That concludes our presentation. We're happy to take any questions, or if anybody wants to offer any comments on their experience, we're happy to hear those as well. Thanks, Dr. Pecchia.
Thank you, Dr. Sathananthan, Melanie, Jose. Just absolutely tremendous presentation, and the sharing of your knowledge, with real cases and the impact that this technology, CGM, kind of married up with virtual care to overcome typical barriers to care for anything, but particularly diabetes. It's just a tremendous gift. Thank you for doing that. I'll start off with a question and leave more than adequate time. We still have about 15 minutes or so, the Q&A. Given that all of our patients don't have the motivation that the one gentleman that you just presented seemed to obtain when they're struck by lightning, I think you had mentioned that was part of his history. I've had a couple of patients in my career that were survivors of lightning strikes. And for whatever reason, they seem to be very highly motivated for their self-care and involvement in their own healthcare. So I'm not suggesting that we have all of our patients go out and get struck by lightning, but I think there's a lesson learned there. And then also individuals who are combine that with his case as well, being a mountain dweller, which clearly, especially this winter, from a place that literally, for those of you who don't know the campus at Western University, as the crow flies, is only maybe 10 miles as the crow flies from the top of some of the highest mountains in Southern California, the fastest growing mountain range actually in the world, the San Gabriel Mountains. Anyway, I think that is a great example that almost within visual sight, we have people that really cannot get down to brick and mortar medical offices. And so to use this technology to, facilitate monitoring them and delivering basic care as well as technology-driven care is a super important question. That said, what are the typical user qualifiers, basically patient history? What are the criteria necessary for them, A, to obtain a prescription for a continuous glucose monitor, and also for anticipated coverage by payers, health insurance plans, Medicare in the U.S., military health systems, etc. What are those usual criteria? Sounds in the perfect world like, all diabetics who have any risk for not being tightly controlled or maybe A1Cs that aren't quite optimized would be candidates, and that the cost factors would be ameliorated so that they could all obtain this, but understand that's not realistic in today's world. What are the typical patient criteria that you see that would qualify them for some coverage and or to be affordable for using this CGM technology in particular? Guess I'll direct that to all of you. Whoever wants to.
I could start, and then Jose may have some also things to add because our pharmacy team really does play a big role in helping us get these devices covered for our patients. I would say the criteria differs depending on what type of insurance they have. The coverage is improving, but some of the things that the payers are looking for is many of them only want to cover these types of devices for patients who are using insulin, and many times they want insulin that's being injected more than one time per day. So it's typically a patient who's on a basal bolus type of program. For some patients, they want to see that they've had hypoglycemia and so that obviously this type of device can help prevent severe hypoglycemia by warning the patient that the glucose is starting to drop. They often also cover it if there's some sort of issue, as Melanie mentioned, like perhaps some neuropathy where the patient finds it painful to check their glucose, or some issue where they cannot do figure stick glucoses. They often cover it if the patient is poorly controlled or has wide fluctuations in their glucose. So it all depends really on the payer. Each one has different requirements. I would say the coverage has improved, because for patients who we prescribed it a year ago, it wasn't covered. Now for many of them it is. But did you have anything else to add, Jose, on some of the questions that you're asked by the payers?
Yeah, sometimes it's like she was saying, sometimes having difficulty just trying to not trying to prick their fingers, doing a finger prick, is something that make them qualify for it. It's something that patient does not like to do. But again, they have to be in the insulin, being in multiple injections, type 2 diabetic. Sometimes patients who are type 1 diabetic just on insulin can be eligible for them to get it as well. And recently, particularly in California, they opened up the eligibility once more. It should be updated now, hopefully on the Medi-Cal end for California, is that now the patients do not need to be here on the California multiple doses, just one dose of insulin a day. That will be enough to qualify them. That's the only difference. But everything else you said, Dr. Sathananthan, was pretty much on the mark.
Once the patient has these devices, it's very convenient for us and for them. But I will say we do have a team of pharmacists working to get these devices covered.
Right.
I know for myself, once Dr. Sathananthan and our pharmacists work their magic and get the CGM, it's amazing to me showing patient the graph, some of those graphs that Drs. Sathananthan and Zamora showed us. When they see that relationship to something that they've eaten, it's such an aha moment. And I think that it's so relevant because they can actually see it. It's not just, the dietitian is telling me to, eat more fruits and vegetables and not eat any deli meats and whatever I'm saying. When they see it, it makes so much more sense, because it's what it's showing what their body is doing. So that's the part that I enjoy when I work with my team, is having those successes, each of us with the patient.
Great. Thanks for that. And one follow-up question to that is for those patients who either your team or the patient themselves feel that it would be beneficial to them, but it ends up not being covered, right? So that the distance between the patient driven desire to use the CGM and or their care team, but the payer is not going to be involved. Let's say they've denied coverage. What is the reality of the cost point, the price point for a patient to say, hey, I'm fine, I understand it doesn't meet the criteria, I would still greatly benefit from using this device? What are we talking about in terms of US dollars, kind of the one-time upfront costs and or ongoing costs for use of a CGM?
I briefly looked up the Libre 3, and the Libre 3 can be used with a smartphone. So if you just get the sensors, it's approximately $150 per month for the sensors. The Dexcom, that would be a higher price point, but probably the most affordable would be the Libre now, which approximately $150. Looks like it would be the cash price per month for sensors. Mm-hmm. For patients who can't afford those, as I mentioned earlier, there's this professional CGM. We don't have that in our clinic, but what we do is we make use of the samples provided to us by some of these manufacturers. And what we're able to do is just get a snapshot in time of how the glucose is running. So with one of those samples, we can put it on for 10 to 14 days, depending on what type of device it is. We can see how they're doing for that 10 to 14 days. We can make adjustments to their regimen, and then maybe we can bring them back in 3 months. And if we have another sample available, we could use it again. So just because the patient can't wear it daily doesn't mean that you can't use it periodically to also get a snapshot of how how they're doing. And just as Melanie said, seeing the patient's diet changes in real time, how that's playing out on the CGM, in the same way we recently saw a patient who was having hypoglycemia after a significant amount of exercise. So that showed the patient that yes, the exercise was bringing their glucose down, and we were able to back off on some medication because they plan to do that regularly. So it can be advantageous that way also.
Great. Thank you. Kind of looking for a pathway for folks that are in under-resourced environments, particularly the global offsite care universe served population is all about that. Can these devices actually be autoclaved or sterilized in some way and shared in remote environments?
That's a great question, and I'm not aware that they can be, although it's a great question. They are disposable once that filament, which is measuring the interstitial glucose, is placed. It really can't be placed again, as far as I know. So that's a great question. Maybe something we could ask our local reps about that, but I'm not aware that it can be.
Thank you. Okay, others, we have about another 5 minutes or so. Any additional questions from the audience or posted in the chat? Taking a look there.
I see a question.
I have a question.
I have a question too. Okay. Yes. Good evening, everyone. It's nice for the. Let me thank Airani for the presentation. Hope you can get me clear. Now, I missed the first part of the presentation. My network is so unstable today. So maybe in 1 or 2 words, how does it exactly work? Is it an invasive kind of device, or it's a non-invasive? Like, how does it measure the glucose in real time? Because that's the part that I failed to connect to the last part of the presentation. Maybe in 1 or 2 words, can give me that recap, how the device actually works. Thank you.
Sure. So these continuous glucose monitoring devices are measuring the interstitial glucose versus what we would see in a traditional glucometer, which is measuring the capillary blood glucose. So most of them actually are quite small. The Libre now is about the size of a quarter. It's quite flat. The Dexcom is a little bit larger, but the only thing that's under the patient's skin is a small filament, and it stays there for 10 to 14 days, depending on the device, typically. And most of the patients don't complain of any pain. The main frustration that I think we see is that if they bump it or they sleep funny or they then that falls off, and here the pharmacy won't refill it for them early. They only get a certain amount of supply for the month, and so that's probably the biggest complaint that we get. But it's not too invasive. It's just that tiny filament that's under the skin, and so most patients tolerate it well. There are adhesives that are often purchased outside of patients' insurance. Many patients purchase those additional adhesives to wear over the device to prevent it from falling out, because once patients are used to using this, when it falls out, they get very frustrated for that week or so that they have to be without it, and most of them don't want to go back to using their glucometer.
Great, thank you. Any other questions?
Mary.
Thank you.
Thank you for a very interesting presentation. I wondered if you have any experience with diabetes insipidus on your telemedicine or in work with people.
Yes, as an endocrinologist, I have seen patients with diabetes insipidus. I would say that's much rarer than the diabetes we're talking about today. But yes, I do have some experience treating patients with diabetes insipidus. This type of device obviously wouldn't help those patients, but I'm happy to, if you have a question, I'm happy to try to answer that as well.
Well, should I do it on chat, since it may not be interesting to everybody, but
sure, you can send me a chat message. Sure.
While we're waiting for final questions, also a final question from yours truly. When if not already available, will artificial intelligence be able to take the data output from a CGM in real time and deliver that into the electronic medical record, which is reflective of the patient's reality, right? The medications they're taking, their other personal medical history, social history, their dietary status at that point in time, their body weight, other vital signs. Any progress with that in the platforms, the software platforms that are being used to kind of host that data output from the CGM? That makes sense?
I'm not sure if I 100% got the question. So as Jose showed, there are different platforms for software available for each of the different devices. Those currently don't link with our current electronic health system. We download it from there and we import it into our current health record system. As far as AI, I don't know that I would consider this AI, but the patient that Dr. Zamora showed who was switched to an Omnipod, that's probably the best type of technology that's available right now, where you have a CGM communicating with a pump and self-adjusting the insulin. The only thing the patient has to input is the amount of carbohydrates that they're eating with each meal. Otherwise, the insulin is being self-adjusted with the data it receives from the sensor. So that's, the closest we have to an artificial pancreas right now. The other thing I would say is many of the downloads provided by these companies do offer tips on how to adjust the regimen. So for example, if there's hypoglycemia overnight, then the software itself will say, consider reducing the basal insulin in this patient. So they give hints also as to how the regimen could be adjusted based on the data from the CGM.
Great. That's very helpful. Thank you. Okay. It looks like we're at the end of our hour. Thank you, everyone, for attending. Thank you to our panelists and presenters today. We're just very thankful and grateful for your donating your time, expertise, experience, and hopefully that plays out for a better world for our patients and those who take care of them. So I will hand it back to Marielle, and who will also remind you of the availability of CME for this presentation, kind of how to do that. And with that, I'll hand it over to you, Marielle.
Dr. P, if you don't mind, there is another question in the chat. How painful is the application of CGM device?
I'll let Dr. Zamora take that.
Yeah, I'll take that one. So I've applied many CGMs. I have not one patient that's complained of the pain. It's not painful at all. As Dr. Sathananthan mentioned earlier, it's only a small little filament that's from the sensor that will go on the patient, and they don't feel it at all. So yeah, you won't have patients complaining of pain at it.
All righty. Thank you, Jose, Melanie, and Dr. Sathananthan for this insightful lecture. We are coming towards the end of our time here. As a last reminder, please use the link provided to receive your CME credits. If you would also like to sign up for our monthly Global Grand Rounds, please click the link to the JOT form. With that said, our next Global Grand Rounds will be on December 13th. And as always, we appreciate your participation and continued interest. Have a great rest of your day, and we hope to see you again next month. Thank you.